Hi, and welcome to episode 24 of the Unpacking Weight Science podcast called Starving in the Intensive Care Unit. I'm your host, Fiona Willer, weight-neutral professional development dietitian, academic and size acceptance advocate. Our learning goals for today are to understand the various phases of the human body's response to severe trauma and their impact on bodily resources, to recognise the considerations for nourishing larger-bodied people in the ICU, and appreciate key calculations for estimating energy and nutrition requirements for larger bodies in critical care. So it's been quite a while since I personally stepped into an intensive care unit as a dietitian, so I had to go back to my textbooks and into the up-to-date research literature for this episode. I started out by wondering whether larger-bodied people were hugely underfed in intensive care in the same way that larger-bodied people are typically underfed when they're on the usual wards, like when they're recovering from surgery or during bouts of chemotherapy, when they're immunocompromised. In these circumstances, the most appropriate prescription is usually a high-energy, high-protein diet, which minimises muscle wasting and loss of condition, helping them to heal faster and get out of the hospital faster, back to their usual lives, but only if they're receiving enough energy to meet their needs. But the intensive care unit is different. It's the very pointy end of medicine. It cares for the kinds of people in the kinds of circumstances who, until a terrifyingly short time ago, would have perished almost immediately, and in very many countries with fewer medical resources or limited access to those resources, still do die without possibly getting another shot at life. So this means that the ICU is conceptually, intellectually, really exciting. Amazing things happen there. The staff are heroes, trailblazers, fate tempters. In real life, most ICUs are loud, with monitoring beeps and the sound of mechanical respiration, but really quiet with voices. They're strangely calm places, but where the lights are on all the time and the staffing remains pretty stable. It's like the rhythms of life, day, night, meal times that do exist in other parts of the hospital don't exist there. It's not rushed like the emergency department most of the time. Specialists breeze in and out, ICU doctors hover and consider, and ICU nurses attend to cares and stay with their one patient for their whole shift. The people inhabiting the ICU as patients have tubes to deliver things into the body and other tubes to take all of the body's wastes away. And most of the people are pretty comatose or close to it, being kept heavily sedated while their body tries to desperately cope with whatever's happened and keep them alive until they can start to heal. People come into the ICU due to things like critical heart or lung issues, severe trauma, like from a car accident, for example, after complex surgeries, extensive burns, and sepsis, which is blood infection. Not all critical states are created equally. Some people are in there for a little while following tricky planned surgery, particularly heart or lung surgery, and some are in there after getting mangled in a car wreck, essentially elective versus non-elective admissions to the intensive care unit. You can imagine that the heart patient has far less physical trauma to deal with than the other person, even if they're both in need of close monitoring and management of their organ function. But it's hard to justify considering them equal in the eyes of nourishment status or trauma. They come to the ICU in all the states of nourishment that exist out there in the real world. They come in malnourished and well-nourished, unfit and fit, with non-exciting medical histories and with super complicated ones. The already medically compromised and the fighting fit, the very young to the very old, and they're all humans that are going to have to cope psychologically in their own way, if they survive, with having been on the brink of death in the intensive care unit. A dietitian's job in the ICU is to advise on the appropriate type and amount of nutrition support, which might be through tube feeding or through a nasogastric tube, the nose tube, or through a percutaneously inserted gastrostomy. That's a PEG tube that goes through the skin on the abdomen straight into the stomach or intestines if it's a jejunostomy, or vein feeding, where very different types of nutrition substances are decanted straight into somebody's bloodstream. And that is used in the case where nourishing someone through their gastrointestinal system is not possible, or what is possible in that way is insufficient for their needs, so they need additional feeding through their vein. We keep an eye on fluid balance along with the doctors and nurses because their fluid and carbohydrate intake comes from their intravenous solution, their IV solution, as well as the feed that we're giving them. Various nutrients are in flux in their body, being expelled from body tissues, as well as being contributed to by their nutrition support. All of those have to be scrutinised for their impact on whatever the person is in ICU for, and which or how many of their organs is struggling. Depending on the hospital and the qualifications and skills of the doctors and dietitians, the dietitians may be in charge of feeding, with the doctors happy to let them be, or the doctors might be responsible for signing off on the feeding plan, with advice from the dietitians. By the time someone is eating things with their face again, they're usually back or soon to be back on the regular ward. Providing nutrition care to somebody in intensive care is quite different from other areas. There's people in a really controlled environment. They're not making any choices for themselves, and they're mostly unconscious. And with that comes the potential for those making the decisions to make judgments about body weight that you would not necessarily make out in the real world, like about how you might have extra stores that you could do with losing. Malnutrition on the way into the ICU is incredibly bad news, and this includes recent intentional weight loss and intentional weight suppression. So people who've lost weight recently, been on a diet, or those who are white-knuckling the weight loss maintenance part. And both of these states should be considered undernourished and should be investigated for malnutrition. And the biggest risk in the ICU is sarcopenia, which is basically muscle wasting, the kind that happens in the quite elderly, associated with frailty, and also in people who are fairly inactive. And what else can cause sarcopenia? Yep, weight loss. Your best bet is to stay as fit and strong as possible for you, no matter what your weight, BMI, or abilities. Larger bodied people, if they're relatively active and well nourished, usually have much higher muscle mass, putting them in a superior position going into the intensive care unit. And people of all shapes and sizes with low muscle mass tend to die more readily in the intensive care unit. So it's super difficult to carry out nutritional status assessments on people in the ICU, as we can't ask them about their histories, we can't ask them about their appetite or fitness habits, we can't easily assess their strength or muscle stores when they're lying flaccid on the hospital bed. Even if we can get them on the scales, fluid balance is all over the place, so it's not accurate. Plus, of course, weight is a pretty sketchy means to assess body composition in the first place. Again, weight change might be pertinent sometimes, but weight itself is not really properly predictive of anything important. On top of that, people in the ICU are hypermetabolic. That means their body functions are working at overtime to try to cope with and fix the physiological mess that's going on. The extra energy required to do these things varies hugely depending on the circumstances. Burns victims in particular have hugely increased energy requirements because they're broken over a lot of surface area and literally leaking nutrition. The list of potential measurement errors that mess up our energy calculations is endless. So the first big challenge of nourishing people in the ICU is the question of being able to accurately calculate their energy requirements. Once that major problem is dealt with, there's the question of how much nutrition to actually provide them with, what kind of nutrition should be provided, when it should be provided, and whether this needs changing as they proceed through recovery. Now, the problem for larger bodied people is that they have their kilograms stolen by the use of adjustments that may result in their energy requirements being underestimated, sometimes hugely, and then they have their lower calories per kilo allowances prescribed because of their BMI status. So there's two steps that can go wrong. Initially with energy estimation, and then with the prescription of energy based on that estimation. So I went to my textbooks to brush up on acute phase response and nutrition in critical care. Up-to-date ones, not the originals from 15 years ago. My big, expensive clinical dietetics textbook is a mere 3 years old and still the most current edition of it available. Human response to critical illness demonstrates a few different phases, generally described as ebb and flow, before transitioning to a recovery or rehab type where they get better, or chronic phase where they linger in a more stable but not properly recovering state. The ebb phase comprises the hyperacute early phase of hemodynamic instability, which is a reason for ICU admission. That's the first 1 to 2 days where their blood flows all over the place. And then the flow phase includes a subsequent period of metabolic instability and catabolism, which can be more or less prolonged, so days 3 to 7. And then after that, a later period of anabolism or proper recovery. So the ebb phase is first when things are really unstable. This is life and death time. The flow phase, they've been stabilized, their blood amount is stabilized, and it's just the metabolic processes that are trying to cope with all of the physiological challenges that they're under. And that is a period of catabolism, which is basically tissue breakdown. That's the first week. And then after that, that anabolism, which is tissue building, again, a proper recovery. So really the first week is very high intensity when getting over a critical illness. During the ebb stage, we want to feed pretty early if we can and use the gastrointestinal tract, and be careful not to overfeed people as it can cause issues. I'll talk more about that later. During the flow stage, it's time to provide nutrition, preferably through the gastrointestinal tract again. From my textbook, the ebb phase happens immediately after injury. It's related to hypovolemia, that's low blood volume, shock, tissue hypoxia, so the body tissues are starved of oxygen, putting it at risk of tissue death, decreased cardiac output, so the heart isn't pumping as much blood around as usual, decreased oxygen consumption, so your body isn't using as much oxygen as usual, lower body temperature, and glucagon, which is a hormone, increases, so insulin, another hormone, decreases, so the liver produces glucose out of protein in that circumstance. Overfeeding someone of any weight in the intensive care unit during this phase needs to be avoided because of its impact on messing around with blood sugar levels, inflaming the liver, and bumping up carbon dioxide production, which can then impact on oxygen absorption and prolong their time on the respirator. So we want people to be able to absorb as much oxygen as they can, and if we overfeed them, it means that they're blowing off more carbon dioxide, which pushes across their ability to absorb oxygen through their lung tissue. So particularly important during that first 72 hours, that ebb phase. So the recommendation during this phase for everyone is that no more than 70% of their energy usage should be replenished with feed during this time. I think that's fair enough. In times of acute response to physical trauma, the body does not access fat tissue as a preference. It's after body protein to make the components to respond to the mangled tissue with. It's making sugar out of proteins. It's also making carrier proteins out of proteins. And it's trying to attend to that broken tissue with the protein. Having these protein needs met is really important to slow the looting of that muscle tissue. So you don't want too much energy, but you don't want to provide loads of protein. Having had weight loss surgery or any surgery which has messed around with the structure or order of your digestive tract will impact on your ability to absorb that nutrition support that's being provided through tubes. That all-important protein goal, getting enough to repair and restore, may float right by where it should be absorbed unless it's already in amino acid form for some, especially if your stomach's been messed with. You want those proteins in a form that can be absorbed pretty readily. Typically, the more severe the situation the person is in, the larger the hormonal response. So the stress, high blood sugar effect is really predictable and expected. It's part of its job, along with some kidney hormones, is to keep that blood volume up. So usually we freak out a bit about high blood sugar levels out in the real world. In the critical care unit, they're completely expected. That blood sugar is working overtime to try to keep your blood volume up to stop you from dying. The body can't do what it needs to do with insufficient blood volume, and if you lose enough, you're dead pretty quickly. There's also pro-inflammatory and anti-inflammatory proteins circling around looking for the trauma sites, and basically the blood that's there is full to the brim of busy bits on their way to fix the trauma sites and accessing bits and pieces needed from the non-traumatized sites. On top of that, some people have infection processes going on, causing inflammation, high temperatures, fast heart rate and breathing rate, and pussy blood. And as one thing leads to the other, multi-organ failure may start to happen. The function of the gastrointestinal tract is impacted by this storm of events raging around it. Often the lack of blood flow to the guts, even for a little while, can result in a condition called ileus, where the gastrointestinal tract loses its ability to push its contents along. So basically the muscles check out. Early feeding by tube can prompt the guts to start working again and encourages blood flow, which helps to avoid the tissue damage to the gut lining, which then can cause other problems. So you want to feed early. Then with fluid resuscitation, that is the blood volume returned to closer to normal via transfusions or IV fluids, and the heart's working more normally and oxygen getting to the tissues because its transport system is back online, it starts the phase called the flow phase. Again, from the textbook, the flow phase is characterized by increased cardiac output. The heart's pumping out more blood than usual, higher oxygen consumption, higher body temperature, higher energy requirements. The body's energy use is galloping along. The body's protein stores are being ransacked in a catabolic frenzy. High blood sugar levels, high blood fats, high circulating insulin, catecholamines, including epinephrine and norepinephrine, they're our panic hormones, glucagon and cortisol, the stress hormone, which is telling the body to break down muscle, which then ends up in the liver to make glucose and acute phase response proteins. So rather than fat tissue being used first, as it is in regular semi-starvation, it's proteins that are in high demand, and they're being raided from skeletal muscle, the muscles that move bones, as well as gut and heart muscles. Loads of protein is considered good in order to reduce that cannibalization of skeletal muscle, as I said before, except in cases where the kidneys are compromised. There's also some questions around whether intermittent or continuous provision of protein is better, given that in healthy adults, intermittent protein intake results in better muscle building than continuous. But the nutritional situation for people in the ICU is not like dieting, and the main factor setting them apart is that inflammatory response from bodily trauma. While people are in this phase of responding to trauma, it's not physically possible to start to recover muscle mass. The body will simply not do it. The goal here is to try to slow muscle wasting by providing enough proteins from external sources. Now, what about specific nutrition recommendations during the flow phase? Well, the guidelines in my textbook from 2016 for this stage are as follows. Minimize catabolism. Meet energy requirements but do not overfeed. Use indirect calorimetry if possible. Non-obese, 25 to 30 calories per kilos a day. Obese, 14 to 18 calories per kilo per day of actual body weight. Meet protein, vitamin and mineral needs. Establish and maintain fluid and electrolyte balance. Plan nutrition therapy. Need for pharmaconutrients, physical therapy and exercise. So here we've got our first mention of higher BMI as being a consideration. As always, this gets my blood pressure up, so I did a couple of calculations. Taking a theoretical patient with an average height and a BMI of 29, I worked out how much energy they would be prescribed according to this guideline, then how much energy they would be prescribed at a BMI of 30, which was the cutoff. The difference in kilos for this person between the BMI of 29 and 30 is 3 kilos. Turns out that works out to being given 38 to 42% less energy than what they'd be given if they were physically 3 kilos less at that tipping point. The actual calorie deficit, I'm not going to say, but it's eye-watering. Remember that the general recommendation is that people's energy requirements are met during this phase. The so-called ideal body weight for someone with a BMI higher than 25 is usually set at what it would be if their BMI were 25. For this person, their energy prescription as instructed with a BMI of 30 would be 67 to 72% of what would be prescribed if their BMI was 25. That's an energy deficit of 28 to 33% for the person at a BMI of 25. As in, it would be a pretty severe weight loss diet for a person with a BMI of 25. For the person with a BMI of 30, that's an alarmingly low energy intake, well below their basal metabolic requirements. In fact, that prescription for someone with a BMI of 30, that amount that I worked out before, is less than it would be if their BMI was 18.5, which is the cutoff under which the label underweight is applied. Basically, there is no way that people with BMIs higher than 30 are having their energy needs even close to being met at these recommendations. No way. Now, I'm open to the possibility that managing a larger body in the ICU has some considerations that are different from managing smaller bodied people, but this is so outrageously different that I felt physically sick. Usually, bodies work on a sliding scale because someone at a BMI of 25 is not that different from someone with a BMI of 28 and not that different from someone with a BMI of 30. Human bodies occur on a sliding scale and their intensive care management should happen similarly. So from there, I hit the recent research literature. Had anything changed since my gold standard dietetics textbook was published? Now, there has been considerable debate about how to calculate the energy needs of larger bodied people outside and inside the ICU. Of course, the compulsion is to underfeed if given the opportunity because of the gross perception that having a person leave the facility at a lower weight is a gift to them and the community. So, the ICU energy considerations sit on top of all the regular controversy about energy calculations for larger bodied people. The predictive equations are okay for smaller bodied populations, but pretty awful for individuals, and they're so hopeless that most ICU guidelines say not to use them at all, and either use direct measurements of metabolism using carbon dioxide respiration, or to use the calories per kilos methods in a similar fashion to those in the textbook. To quote from the Nutritional Support of the Critically Ill Obese Patient from 2011, although the obese patient has both an increased lean body mass and an increased fat mass, the proportion of the two varies widely and differs significantly from the non-obese patient. Using the actual body weight in the energy calculations of the obese patient overestimates the caloric requirements. However, given the larger lean body mass, using the ideal body weight greatly underestimates the caloric requirements of obese patients, thus exposing them to an undesired state of catabolism. Multiple studies have attempted to validate the use of more than 25 equations in obese patients with conflicting results. Most of these studies reported serious inaccuracies of those equations in the morbidly obese population. I'm sorry about the language there, that is what's in the quote. So ideally, the patient's energy requirements should be measured properly using indirect calorimetry, which is basically a machine that collects and analyses the amount of carbon dioxide in the breath of a person over a given period, from which their metabolic rate can be calculated. And this should be done regularly while someone's in the ICU as their status changes. Their energy requirements are going to change with that too. Saying that, loads of things will throw off the results, like if a person's in acidosis, has a chest tube so they're not breathing properly, or is being mechanically ventilated, as in they're being kept alive using a machine that breathes for them. That makes these calculations tricky. Consistently, the papers I was reading noted a survival benefit for people with BMIs between 25 and 40. That's the so-called obesity paradox, alongside the recommendations for feeding people with BMIs over 30 no more than 70% of their estimated or actual requirements. Yes, you heard that right. A larger body gives people a better chance of getting out of there alive. And that said, there are loads of potential reasons for this beyond just body mass. Remember that if we can strongly make the case that BMI is garbage when we're talking about negative outcomes, which we can, then we can't just run with it unexamined when it's associated with good outcomes. The measure is still pretty garbage, but there is this relationship. So where did this severely hypercaloric diet come from? Well, a few sources mentioned that the origin was a hospital-based weight loss program from the 70s, to which I went, what? So I went and had a look. So basically there are these two studies. One's from the 70s in otherwise well people who were in a clinical trial for weight loss at a hospital living there. So this other one was from 2002 where they trialled that energy level, the 70% energy level versus a higher energy intake, closer to what smaller bodied people get proportionally. And that's it. There's just those two studies. And even this quote from one of the papers, the idea of protein-sparing, hypoenergetic feeding in obese critically ill patients was inspired by a weight reduction dietary strategy commonly known as the protein-sparing modified fast and was used to induce weight loss in obese patients who were not ill. Okay, inspired by. So their lower calorie targets were inspired by a weight loss trial during the 70s. I went to it, I tried to find the paper. I found the paper, but I couldn't access anything except the abstract, unfortunately. But it tells me that it involved 7 people with diabetes who were fed a very low calorie diet that had adequate protein for their needs, so high protein, low calorie, published in 1976. 7 people, 1976. Anyway, you can imagine what I'm thinking about that. The second study, the randomized control trial, had 40 people in it, and they found that the intensive care outcomes were equivalent whether people were fed around 70% of the energy that their body was expending or 100% of the energy that their body was expending. Basically, that it didn't make a difference to intensive care relevant outcomes if they were fed a high protein feed at the level of energy that their body's using, or if they're fed the same amount of protein with much lower energy intake overall. In practical terms, this means that the feeds for larger bodied people were kind of set and forget. They weren't changed between the ebb and the flow stages. And the benefits of this in most of the papers that were recommended the use of that 70% were along the lines of cost savings in terms of feeds and, oh, look, bonus weight loss, we're helping them. When I read these things, I also look for evidence of overreach. That is, for example, when you go to the dentist and they start talking to you about your weight, or when you go to the GP for an ear infection and they bowl you up about your weight. It's not the actual job of ICU physicians and dietitians to be hand-wringing about the perceived weight-related diabetes or heart disease risk decades from now. And yet, implicit in the severely hypocaloric prescription is the benefit of weight loss. Why not help them lose weight while we've got them? Never mind that the population that those background chronic disease risks are derived from are very definitely not equivalent to people who've had a stint in the ICU. These people need to stabilise the person, get them back to the ward to recover, and then those doctors need to get them out back into the community and back to their lives. Now, a quote from Nutritional Care of the Obese Intensive Care Unit Patient from 2005. Contrary to the general belief, acutely injured obese patients have a catabolic response to injury similar to that of normal weight patients, which puts them at equal or greater risk for nutritional depletion. This is due in part to the fact that even with large lean tissue stores and excess body fat, obese individuals are likely to develop protein-energy malnutrition in response to metabolic stress. And then, of course, in the paper, they go on to moan about diabetes and insulin resistance in larger-bodied people as if it isn't relevant in smaller-bodied people too, or a major factor involved in simply aging rather than being specifically weight-related. Then I found this opinion or consensus piece from 2011 saying that not all obese patients are at the same risk. Stratifying that risk over a wide population of patients in the intensive care unit may be difficult if body mass index alone is used. Evidence of comorbidities, the presence of metabolic syndrome, and specific complications such as end organ disease or thrombogenesis may help identify the obese ICU patient at the highest risk. Which is kind of exactly like people with BMIs below 30, right? They go on to say, clinicians are often on their own to design the appropriate nutrition regimen, determine the needs for indirect calorimetry, select the most appropriate predictive equation, decide whether the pharmaconutrition should be used, identify tolerance measures, and set the appropriate monitors of feeding for the obese ICU patient. Few prospective randomized trials are available on this topic. BMI is only a crude indicator of both the risk of obesity and the need for specialised nutrition therapy. Obese patients with a BMI of 30 to 40 may require a lesser degree of specialised treatment. It may appear paradoxical, but obesity does not protect against adverse nutrition states and acute malnutrition. The importance of enteral feeding is the same in the obese critically ill patient as it is for lean counterparts. And this, the perception of increased nutrient reserves does not justify prolonging periods of nil by mouth. Although greater fat mass in the obese patient may represent an energy reservoir, problems with futile cycling, insulin resistance, and poor fuel utilization may actually predispose the patient to greater losses of lean body mass in nutrition stress. Delays in feeding reduce the value and impact of enteral nutrition for the obese ICU patient. So, there's an acknowledgement that factors like insulin resistance make things more difficult to stabilise, and they call this metabolic derangement. And I see this through Hayes' eyes as probable factors that drive a higher body weight in some people. So it makes sense that these factors are present in larger bodied people, and I get how that impacts on a clinician's ability to control things like blood sugar levels. Again though, prescribing severe starvation as a way to bring down blood sugar levels is unnecessary when other regimens may do the same job without adding to muscle wasting. In another paper, this time from 2014, the association of increasing BMI and mortality in the general population cannot be extrapolated in the critically ill patient. 3 recent meta-analyses attempted to elucidate the impact of obesity on ICU mortality. Altogether, these studies are highly suggestive of lower mortality risk in mild and moderate obese patients, whereas underweight patients display an increased mortality risk. And now on to the cutting edge. There are new guidelines dated February this year from the European Society for Parental and Enteral Nutrition, or ESPEN. Their overall recommendation: feeding to 70% of measured energy expenditure using indirect calorimetry during the ebb phase had the best mortality outcomes, followed by complete feeding once the flow stage is reached. That's for everyone. So use indirect calorimetry so you know how much they need right now and feed them that much, as in feed them what they're using. And ideally measure their nitrogen output so you can replenish their protein losses too. If you aren't able to measure their actual energy usage, use adjusted body weight to calculate energy needs. Basically, To work out adjusted body weight, you need to work out what the patient's weight would be if their BMI was 25, work out the difference between that weight and their actual weight, take a third of that number and add it back to the weight they'd be at BMI of 25, and you've got the adjusted body weight. When I went through training, it was 25%, so it's increased from 25 to 33. Then treat that as if it's their actual body weight and feed them 100% of their needs according to that, using the 20 to 25 calories per kilo range that's used for people with lower BMIs. You can see then that there is this danger zone for potential underfeeding, but it's not as bad as before. Our theoretical person with a BMI of 30 would be fed as if their BMI was almost 27, and it would at least be getting more than if their BMI was 25. The new guidelines also note that historically ICUs have intentionally underfed larger people by setting ongoing feeding goals at 70% or less, and they've considered weight losses of 2 to 3 kilos per week as acceptable. But the guidelines note that there's been no proper research on the safety limits of this kind of weight loss. They also note, as I found, that the evidence used to justify massive underfeeding was based on small studies and historical use. The ESPEN guidelines also say that underfeeding is bad, defined as below 50% of requirements, as it drains muscle and nutrient reserves and is related to worse outcomes than especially when infections are present. The guidelines most endorsed by North Americans are the ASPEN guidelines. That's from the American Society for Parental and Enteral Nutrition. Their guideline document is Nutrition Support of Hospitalised Adult Patients with Obesity from 2013. They start out by saying that because obesity is considered a disease in America, that treating it alongside the person's other issues in the ICU is appropriate. Because of course they do. This is exactly the problem with medicalising BMI. It gives healthcare providers the justification to endlessly hassle you about your weight when you're conscious, and gives them the implicit power to starve you without your consent if you're unconscious. In contrast to the European guidelines, the American ones encourage extended underfeeding at 50 to 70%, despite rating their recommendation strength as weak and evidence base as low. Again, using that randomised control trial that showed no detriment to short-term ICU relevant outcomes for underfeeding when compared with feeding to energy requirements during the flow phase. I'm super pleased that the brand new European recommendations are no longer supporting huge underfeeding for larger bodied people, but I'm 100% certain that most ICUs, no matter where they are, have not caught up to this update yet. Using these new guidelines, the underfeeding for everyone should only last for the first few days during the ebb phase and transition to 100% of needs feeding during the flow and further recovery stages. For those still using the American guidelines, it's clear that feeding people 100% of their needs is not related to poorer outcomes and should be an option discussed with the patient and their loved ones, along with the caveat that long-term outcomes from both of the options are really unknown. There is a strong case for all ICUs to have the equipment and expertise to measure energy expenditure for all of their patients, especially the larger bodied ones, to save huge misestimations and errors in nutrition support. Nutritional status impacting on important outcomes is also hugely affected by how well people are able to eat after they've come out of the ICU. Even if they've had an optimal stay and met all of the nutrition support goals via tube feeding, if they're put on a diet of insufficient energy and protein back on the regular ward, they'll be back in malnutrition territory, which will of course potentially throw out the long-term health and survival outcomes for them. If you're an ICU dietitian or physician, I urge you to start treating your larger patients like your smaller ones. Don't underfeed them because it's what you're used to doing, or because it's cheaper, or because the pity you feel for someone in a larger body makes you think that helping them to become smaller would be a harmless, welcome gift. I urge you to conduct research in your work to extend the knowledge we have about feeding larger bodies for optimal outcomes in the ICU. If you're the loved one of someone in ICU, I urge you to discuss nutrition provision with the care team, advocating for your loved one and asking for their actual energy requirements to be honoured where possible. Not having the means to measure actual energy expenditure of patients in their intensive care unit is worthy of a complaint to the hospital's governing board, and for less well-resourced facilities, worthy of community fundraising efforts to get some new equipment. And my final word today. Your body does not know that it falls outside of what society and medicine deems is an appropriate weight. Fat bodies want to live just as much as smaller bodies. Their physiological responses are just as energetic as smaller bodies when facing life-threatening physical trauma. If I were your ICU dietitian, my goal would be to ensure your current body is nourished and treated according to the best science we have, that it gets what it needs now to survive acute trauma, to heal, to manage, to recover, to thrive. So, that's it for this episode. The supporting materials, which include the show notes, research links and self-test quiz, are available upfront for current subscribers, only $5 a month, bargain, or can be purchased in a bundle if you're catching up later. See Unpacking Weight Signs for details. And next time, episode 25 is Weight Loss is Not a Fertility Time Machine. In this episode, I'm going to take a look at weight loss recommendations for fertility, the research they're based on, and the gaping holes in it to find what's real and what isn't when it comes to weight and fertility. Until next time, goodbye.